Good afternoon, or maybe some other time of day, depending on which time zone you're in. And we are going to actually be asking you that, so get ready for that. Hi, I'm Paul Volberding, and I'm really happy to welcome you to this informal discussion that I'm going to be having, actually that we're both going to be having. I'm talking with Peter Chin Hong. Peter is at UCSF and has been very involved in HIV and infectious disease in general, but now is especially, like a lot of you probably, very involved in response to COVID. So a little background here. This is a very informal discussion. We're going to give you a chance to ask questions. We'll have you ask those questions on the Q&A function on your Zoom screen, and we'll be watching those, and then Peter and I will respond, and we're going to be talking to each other. So Peter is likely to ask me questions as I will be asking Peter. We've done this now, these kind of informal dialogues with the International Antiviral Society USA for a while now, and during the pandemic and the stay-at-home shutdown orders. And the idea is to take advantage of this medium. Zoom we're all using it. It's a way we can get a lot of people together. It's a way we can share ideas, and it's a way we can really do things that are really up to the minute, because we don't have to prep lectures and have slides and the rest. So we look forward to this. It's also a way we can get a lot of people in the room, if you call it that. We already have, I think, 125 people in this Zoom. A number more have registered and may or may not be able to join us. But let's start with, and by the way, we're going to have about 40 minutes of discussion and then 20 minutes for Q&A. So let's start by asking you where you are. So this is open to anyone in the world, but why don't we do an audience response question here and tell us what your current time zone is, if you know it. Eastern, Central, Mountain, Pacific, Alaska, Hawaii. So why don't you take a second to do that? All 132 of you now that are in the room. And then we'll show the answers. So basically a kind of a split between East and West Coast, it looks like, where the population, I guess, is the biggest. 43% in the Eastern, 35% here on the West Coast. Next polling question, if I could. So it's not always easy to pick one of these, but to the best of your ability, kind of where do you work? Do you work mostly in clinical research, clinic sessions, commercial company, community-based health center, government, group practice, hospital-based, or you're training at some point? So let's see that when we get the results. And a wide mix. I guess the plurality is community-based health centers, but with a fair number of people involved in clinical research and some of the other ones, government employees as well. So great. And I'm watching the participants. I see some good friends on the list. I might surprise you, like Kevin Carmichael, and ask you a question as well at some point. I can't do that because your audio is disabled, but it is nice to see a lot of our colleagues joining these programs. So Peter, so I'm a professor of medicine at UCSF. I'm emeritus now. I'm on my way towards retirement, but you're not. You're pretty active, I think. why don't you tell us a little bit about your background? Peter and I were at one program together in Chicago, and one of the people in the audience correctly guessed his origin from his accent. So don't tell us your origin right away. Just tell us your training, Peter.
Yeah. See if anybody recognizes.
Yeah.
Actually, that's been one of the interesting, bonuses of being somewhat in the media sometimes, is that all of a sudden, all the people from the place that I came from recognize me, and they send me emails and like pictures and tell me where like specific restaurants are. I mean, it's been kind of interesting in that way. But
right.
After I moved to the United States from said place that I came from, I was on the East Coast, and I remember like the only time I saw snow before was in my deep freeze when we had this old freezer, and it was defrosting, and I would stick my head in when it was defrosting and pretend it was snow.
Yep.
And then I came to snow, which was at Brown University in Providence, Rhode Island, which was not like the US I've seen before, which is the only time I'd visited was New York. And I thought the whole US was like New York. But then I went to Providence, and Store 24 wasn't even open 24 hours of the day. And I was so surprised because it was not my expectations. I like made snow angels for winter, and then got tired of snow, moved to California, where my friend from growing up was working for Oracle. And then after I ate a burrito every day in Valencia Street, I couldn't really give it up. And UCSF was really everything that I cherished in, what I wanted to do, which was, multidisciplinary. I think that Ward 86 and the program that Paul built was really one of the draws for me as a young trainee, sort of looking for inspiration for the next level. And I was true to the religion of you can stay here forever, which UCSF stands for.
Right.
I've been here ever since.
Yeah, and for the participants in the program today, I won't ask him to toot his own horn too much, but Peter's a spectacular educator and has played a major role in the medical school curriculum, and has spoken on IAS-USA programs before. Peter has sort of developed a niche area before COVID came along of I think transplant infectious disease. Knows a lot about that. We're not going to ask him about that today because we're mostly going to be talking about COVID. But it's great to have you here. And we can't ask the audience a poll. I guess we could design one, but we didn't. So the mysterious country of origin is Trinidad and Tobago. So you're on the Trinidad side, I think, right?
Yeah.
Yeah, good. So Trinidadians? Trinidadians recognize your accent, and that's how I knew.
Yeah.
Great.
So I still carried on my keychain. So these are the colors of the flag. Excellent. It looks a little bit different. Yeah.
So everything in our world changed in the early part of this year. Do you want to give us just a little bit of kind of the earliest kind of recognition and how you started to get involved in responding to COVID?
So I think in the ID division, we got involved in COVID long before the rest of the country did, because we were seeing what was happening in Wuhan, China, and we had felt sort of like a premonition that something was going to happen that was on a much larger scale, even though at that time the Chinese government was playing down the epidemic. They were saying that they were all in control of it. It was, confined to Wuhan after that market outbreak. And and then we saw the numbers were just speaking for itself, which was, again, a premonition of what was to come in our own country, where there was a mixed messaging of data and facts with what some political leader was saying that was completely at odds with each other. And I think at that point, it became clear that scientists had to really be one of the spokespeople for the epidemic, because again, the political narrative was very different from the epidemiology and the scientific narrative. So I think early on we were preparing, we helped the medical center develop strategies for how we would do very basic things. Everyone, as it became more known that it was an emerging epidemic in the US itself, people were becoming very, very anxious. So I think the early epidemic in COVID was all about anxiety. We didn't know how it was spread. And that is very similar, I think, to HIV. And a question I would bring back to Paul too. We were on the front lines taking care of patients. We were afraid of bringing it home. I remember taking my shoes off in my trunk of my car because I was afraid of my surfaces like touching the floor at home, and then my family would touch it and then get ill. You know, I'd changed my clothes before I came in. My colleagues were taking showers at UCSF before they went home when we were in touch with COVID patients. And I think that early days of COVID were really anxious. We were anxious. The people in the community were even more anxious because we weren't getting consistent messaging even early on from our political leaders.
Well, and I do want to talk more about that because I think we still see that in terms of stories to the minute. The story this morning about the HHS spokesperson and his stuff with the messaging of the CDC is something I want to get back to. But I'm curious as to how the ID people, how you all decided to get organized. Did you say, I'm going to take on this, I'm going to take on vaccines, I'm going to take on treatments, I'm going to take on ICU, I'm going to be the spokesperson? Was that ever an explicit thing? Because for the people in the group today, I'm sure you've heard Peter. He's been, a real great star for effective communications nationally. So did that just happen, or was it planned?
I think people in any community have different loves and passions and skill sets. So I think when all of the enormity of COVID became apparent, which was pretty early on actually, there was a need for like somebody who loved doing investigational trials, somebody who loved and was really in the infection control part. There's somebody who loved patient care. And it so happened that all of these ecosystems existed in our ID community here. And then, of course, lots of other people outside of ID, but just speaking for my own community here, we all came together. I remember the seminal ID grand rounds we had where we educated ourselves about COVID, what we knew so far, what was the Chinese experience. At that point, the first few hundred cases of what the Chinese experience had been published in New England Journal. We were looking at data and figuring out how to apply it to us. At that point, there was no known therapy, but we heard about Gilead's drug that was used for Ebola. Gilead was in our backyard. We had a lot of UCSF people at Gilead. So we were getting sort of like the scoop from the inside. And so we had a premonition about remdesivir. Then it was compassionate use. But we all fell into our little ecosystems. And in terms of communication, I'd been teaching medical students, as you said, for a long time, Paul, and yep. It was really my love. I love sort of like taking abstruse ideas and distilling them into easy to understand concepts, because that's what I needed myself when I had to learn this stuff. I needed to break it down into schema and use metaphors. I gave bugs personalities. So I use the same way I talk to medical students to the community, and I think that's how it happened. If you kind of imagine the early stages of when I decided to communicate with the community, was driven by the anxiety and all the questions, and the rest took care of itself.
Well, I think there's a close relationship between education and communications, and obviously you want to communicate an idea, you want it to be effective, you want to get your point across, and I think that's true in media communications as well. One of the things that I'm sure you didn't do was do anything to exaggerate fears or reassure people that nothing was, that there was no problem. I don't know, you want to talk about that? In contrast to some people that we could name.
Yes, no, definitely. My modus operandus was also to be as even keel as possible and to meet people where they were, just like you would meet a student where they are. I think the worst thing you'd want to do is just have like super high expectations, always wear a mask or never leave home, or what are you doing going to the beach? You don't censure people, you don't scold them. You kind of meet them where they are and you begin that dialogue. And I think that was always my approach from the beginning, learning from where my students were. So, reassuring, and maybe being from the Caribbean, that helped.
Yeah.
I wasn't sure but internally we were all having these questions, but I knew that people were really worried and we needed to be as science-based as possible, make linkages to other respiratory viruses we knew. It wasn't like this unknown thing. We had the principles from before, and you applied it and you added knowledge as we began to get more knowledge about COVID-19.
It's a tangent, but one of the things that's been interesting to some of us old timers is that a number of the people that were quite involved in HIV and other issues when COVID came along did pop up as familiar faces now. Ashish Jha, who we see on CNN daily, and all the other networks, and as well, was one of my first chief resident at the VA. Carlos Del Rio, who I'm looking to see if he's on the call today. I know he was thinking about it. At Emory, has again emerged as a real kind of a very effective communicator. And then finally, I won't go on with this, but Bill Hazeltine, Bill and I were among the co-founders of the journal Jades, and now he emerges decades later daily again on CNN. So, but I think the broadcasters look for people like you, Peter, who do have that ability to communicate, and it's a good thing because we sure need it with everything going on these days. I wanted to talk just a little bit about the clinical features that you're seeing. Is your involvement mostly with hospitalized patients? And what about the care of the people that don't require hospitalization? Are they effectively being managed or just being told to manage at home?
I think that narrative is changing, but for much of it, and still today, most of the emphasis is on the sickest of the sick, almost like HIV again. Like, I think our eyes, as we learn more about how to care the sickest of the sick, our minds are opening up to the vast swaths of people who are asymptomatic carriers. And we have very little information still as to, of these 10 people who are asymptomatic carriers, which one is actually going to progress to badness. And what can we offer people in the outpatient world, just like in HIV, to help them prevent their progression? And I think right now, clinical trials are moving in that outpatient direction, but they've been very slow, limited by the delivery of these antivirals or therapies we've had for patients. Because
remdesivir is just IV, right? Remdesivir. So it's like we need a pill, obviously, for that group of people. And one of the things that I did want to talk more about the asymptomatics, because that's been, boy, has that been a poorly communicated. And I guess the issue at some level is just that we just don't know yet what the full natural history of this infection and disease are. But we've heard everything from and then the horrible communication a couple of weeks ago, don't bother testing asymptomatics. And then we've heard that kids don't get infected, or they do, but they don't transmit it. Do you want to clarify some of the issues about the asymptomatic state that you started to talk about?
Yeah, so I would say what we know from several studies so far is that asymptomatic transmission or asymptomatic state is not a myth. It's about 40% of the people who have COVID. In terms of transmissibility by age group, and this relates to school reopening, probably the best study, although it's not always generalizable, is from South Korea, where they looked at like 60,000 cases, people, and they looked at all their cases and went back to their families. And sure, some kids got COVID, some, wide range of people. But it turns out that for the kids who had COVID, if they were under 10, very few, 5 or so percent of the households had some infection, whereas over 10, it was more than 20%, and they acted 10 to 19 acted like an adult, basically. So that's kind of like where we sit, and that's these kinds of studies help public health determine a guidance for, you know, when do you open things? Maybe and again for elementary school kids, because there's so much emotional and cognitive benefits of going to school. That's why that population's been prioritized.
And you know, just the other day I heard, I think some of this is being prompted by this radiologist from Stanford who's now leading in some of the things as Atlas, and speculating, you know, of course, about herd immunity and all that, but serious speculation that the numbers of people that have been infected maybe 10 or more times the number that have been reported. Is that possible? And also the issue of when the earliest cases actually started, because people are now saying, oh yeah, I had a bad cough in December. And you want to talk about that at all?
Yeah, definitely. So really two really interesting questions there. First, the idea of when did it start, and the timeline gets being pushed back earlier and earlier. I remember, you know, when in Santa Clara County in our area, when those cases from autopsy were identified to have COVID, and then there was this technology conference in Las Vegas that was really seen as the likely spread to the Bay Area, because why would Santa Clara Valley, Silicon Valley be the hotspot of COVID in the Bay Area? It made no sense otherwise. There are many more Asians who go back and forth between China to San Francisco, but yet this random place. And then, you know, apparently there was a big contingent to this convention in Las Vegas that the NPR kind of like did an investigation to show, and they found out to Silicon Valley, and that's why Santa Clara County was really a hot spot. But then, you know, people are continuing to go back and back. And of course, it makes, to any clinician or provider, it makes complete sense that if something is happening in China and there's tons of air travel and this thing spreads by asymptomatic spread, and there's a lot of exposure to the West Coast, that it would have been here instantly from, it's just that the WHO essentially offered the US their kit, which was being used widely around the world, including China. US said, no thanks, we'll develop our own. And of course, we know the rest of that story, which is that the testing kits were flawed. The CDC had to pull back on them, and then we had to start from scratch. And then instead of a central distribution, that was the beginning of the end. Each lab in each municipality had to do their own validation, and then you can do your own local testing. So that's what the theme of COVID in the US is decentralization, which is terrible, and the worst thing you'd want to do in an epidemic, much more pandemic.
Yeah, no, I remember thinking back again to HIV, how important the CDC was, how there was a strong sense, you know, there were political issues. Everyone knows about Reagan, you know, trying to avoid it and all that. But I think at every moment we thought that the CDC was the righteous center of the coordination of response. People turned to the CDC for honest answers. And yet with this, there was no, I don't think there was ever any serious attempt to set up a national surveillance, so that the questions that we're still asking today could have been addressed. So just a horrible outcome. But you know, I mean, your comment about the tech in Las Vegas to Silicon Valley reminds me, people on the call today might not all know that the organization IAS-USA that's sponsoring the program today also a number of years ago took on the management of the CROI conference, the centrally important HIV science conference. And just when we were starting to get a sense of what was happening with COVID, it was just days before CROI, and we had a very active dialogue, not quite a fight, but a very active dialogue within the organization about what should we do. Before all the stay-at-home orders had come out, And some people really thought that, it was important to have the CROI conference, that the science was really important. But that's, 4,000 or 5,000 people from all over the world. And we decided at the very last second to pull the plug and to move that to a virtual conference. It was before virtual conferences got to be, the norm. And I'll say that Donna Jacobson, who's the CEO of the organization, and others really just pulled out all the stops and put together an effective conference virtually. But just before CROI was to happen in Boston, in the same convention center,
Yep.
Biogen was having an investors meeting, again, people from all over the world. They didn't go virtual. And that was another one of those super spreading events that resulted in the infection being much more widely and quickly disseminated than it would have been. So these are accidents, but I'm really glad that our organization decided to go virtual. But
yeah, that Biogen event was the Sturgis essentially of
yeah, exactly. So, Peter, you're involved now in vaccine as well as treatment. I want to talk about your various research, but I know that you've been interested in immunology, obviously as an infectious disease person, but again, with your work with some of the novel therapeutics and their infectious complications. But so how did you get involved in the vaccine? Is that another one of those things where it was like, you were interested and you were there, and so you responded? And I do want to talk a little bit about what's happened with vaccine development in the last week or two.
Yeah, so my involvement was really in the therapeutics perspective. And the vaccine stuff only came in as a side note based on my relationships with media. Again, the vaccine stuff was they just wanted me to tell them, to reassure people and to give them what quote unquote the truth was, and to translate the science into community speak. But it was overall, I guess if you would put it in a box, part of our investigational drug response to the epidemic at UCSF and prevention methods as targets. So I think what it illustrates is that all these people came out, all of the woodwork. I remember clinical research stopped for a while in the beginning, and everybody turned to COVID. You could be studying, receptors, and suddenly you'd be interested in COVID receptors, or you'd be studying chemistry, physical chemistry, and all of a sudden you'd be looking at the chemical structures of all these other unused drugs or repurposed drugs. So I think that sort of role, the vaccine part for me, came out of that sort of like therapeutics, and we can talk more about therapeutics, but it was sort of
want to, but let's stay on vaccines for a minute. Yeah. So you weren't directly involved in the AstraZeneca trial, were you?
No, I wasn't involved in it, but I know about our efforts, and I know about what's been happening globally, that's for sure.
And so, we all speculate and watch and listen to speculations about vaccines. I think the dominant thing I've been hearing in the last few days is, well, maybe we're only going to have a 50% efficacious vaccine. Will that be enough? So, and I know this is a guess because we don't have any data on efficacy yet. But you want to talk about what your kind of take is on it? And I also want to kind of get back to the topic that's part of our program today about activism and the public, and think a little bit together about the anti-vaxxers and what kind of strategy, what kind of effective way can we have of meeting those people to try to increase the uptake of this.
Totally. So my take on the vaccine is that it's an arms race, essentially. It's US versus Russia versus China, and US/UK/Europe together.
Right.
And then there's China and there's Russia, and everybody's kind of doing their own thing. I was speaking to a colleague yesterday from Hong Kong University who's very active in the Chinese vaccine, because again, Hong Kong had to sort of like be one of the sites for the Chinese vaccines, even though they've very much academically aligned with UK and the US in many ways. So we've been comparing, contrasting, but right now I think the three front runners, to tell you the truth, are the AstraZeneca vaccine, although it was held in, as everyone knows, restarted in the UK. The US has some concerns about it. We can talk more about that. The Pfizer vaccine, which was a partnership with a company in Germany, and the US-grown Moderna vaccine, which is based in Boston. So those are the three front runners from the US Operation Warp Speed perspective, although there are 7 total that are invested in that realm. From the Chinese perspective, they have a couple of ones that they're working on. And from the Russia perspective, we all know, well, hopefully everybody knows about the Sputnik 5 and the problems around that, which violates the 3 T's of when we talk about vaccines. Trials, and testing. So
no trials.
Recently started, and who knows if they were made up. Some scientists from Italy wrote a petition saying that the numbers in the Lancet were made up because some of the CD4 and CD8 values were the same in patients, which seems very improbable.
Right.
Transparency, nothing was really available for scientists to look at, and trust, because at the end of the day, it really makes this narrative that anything that some governmental organization approves can't be trusted. And I think it probably would jeopardize things beyond Russia, frankly.
Right. And I'm starting to see some questions come in the Q&A. We're not going to kind of turn to that until for another few minutes. But hello to Martin Mass, who is one of the early HIV pioneers here in San Francisco and has a couple questions we'll get to. So anti-vaxxers. Those of us that live in California, I think this might be one of the real hot spots of that kind of movement, if you want to call it that, that's been around for a long time. What do you know about that? And we've been talking about your communications ability and how you are so effective. Have you given that a shot yet? Have you run across people that really need to be convinced that that vaccines are worth at least considering?
Yes, I mean, and it has nothing to do with education or anything like that. One of my best friends, the same friend who convinced me to, well, he didn't have to do much convincing, but was one of the reasons why I moved to San Francisco, graduate of MIT. He's kind of an anti-vaxxer, and I really don't understand that. I mean, it's like what we hear about in the Bay Area, wealthy areas actually are full of people who are anti-vaxxers. And to me, what it was, it's not like a sudden thing, and I'm worried that has building momentum, and I feel the narrative around mistrust on politicians saying they want to have this vaccine approved by this date, which is 2 days before the election, is just doing more and more disservice and providing fodder to the anti-vaxxers.
Yeah.
But I think there's a historical precedent, and if you look back to 1976 when Gerald Ford was promoting the swine flu vaccine that was written about recently, I was on the eve of his re-election, and of course he lost to Carter, but it was a very similar thing where he was speeding up this vaccine, which was, at that point, this swine flu epidemic never happened, but 40,000 people got Guillain-Barré, and I think, or like several thousand anyway, and I think that was probably one of the moments that people began to question vaccines and also the interplay between politics and vaccines. And I think that has just the public began to question it. And I think anti-vaxxers built in on that with the autism and all that stuff.
I was really worried when the AstraZeneca trial was stopped because of a case of transverse myelitis. And I was worried thinking back to the Guillain-Barré, and I just hope that it doesn't make people remember that too much, because I think one of the concerns with the vaccine is neurologic effects, and I don't know. Do you have thoughts on that?
Yeah, I mean, I think many people in the community are worried that this transverse myelitis was actually, I'm such a vaccine fan. I'd hate to sow doubt in people's minds, but luckily we have many other alternatives. Plus, I like the Oxford vaccine until this point. I'm just want to know more information, but transverse myelitis is a bona fide reaction that you can get from vaccines. And the particular adenovirus strain that's used in Oxford vaccine was chosen because it was a chimpanzee adenovirus. So it's super different from humans. The Russian Sputnik 5 is a human adenovirus, and then China, they're using human ones too. The benefit of the chimpanzee one is that you don't have to give a lot to get a huge response because we've never seen it before as a, as a vector. But the problem with it is that it can sort of stimulate your immune system to do all sorts of mischief, including autoimmunity and this immune reaction that could have led to transverse myelitis. The question is, how probable is this on a population level? Because of course, if it is related to the vaccine, it is usually a rare phenomenon.
Got it. I want to talk a little bit, going back to, again, sort of the communications and advocacy part of today's non-theme theme. But I really appreciate your insights, Peter. But, today then we hear, it's been brewing for a few days now, this, the HHS spokesman, Michael Caputo, who apparently has been really strong-arming the CDC to have permission to edit the MMWR, even though he's not a medical scientist at all, because this idea that the CDC has a group that are trying to bring about the end of the presidency. You want to just talk about that a bit? Because I think, we so have come to trust the CDC in our work.
Well, I think that, when you look back, hindsight is always 20/20. And then once we began to know about Caputo, I think all of these weird things that we've been seeing in terms of communications from the CDC makes sense now if they were being strong-armed by somebody higher. And first of all, I think that's a big theme. The CDC has been completely silenced during the whole epidemic, which has been unlike any other thing we've seen before in recent times. Ebola, CDC was front and center. Swine, H1N1, CDC was front and center. Like you said, Paul, they've always been the trust. And part of the reason why I have this spokes pedestal or podium to talk to people in the community is because we get random messages and we don't know who to trust. So, so this role of the CDC has been minimal from the beginning. In fact, there have only been two prominent providers or scientists at the front, which is, Deborah Birx and Fauci. And even Deborah Birx has been somewhat modified in message, and I think a lot of people have been disappointed with that. Yeah. But again, if you want to keep your job, you kind of have to toe that fine line, But coming back to the CDC, completely silenced, making weird recommendations, not disaggregating data by race until they were forced to. Even with remdesivir distribution, a few weeks ago, or months ago, almost a month ago, we were instructed from the hospital not to give the CDC real-time data, but to go straight to HHS, which shocked everyone again.
Right.
So it's just part of the whole narrative of having information filtered through a body that we normally trust. In fact, it's probably worse than, what we would have of wildest imaginations.
So one of the things that we were talking about earlier, Peter, is the kind of the parallels between HIV and COVID in terms of some of these social issues. You mentioned the fear that healthcare workers had. I think a number of the people in the audience today can remember back when we had some real cause for fear before we knew about HIV and how it was transmitted. But boy, did that change with COVID, where suddenly everyone is at great risk. Fortunately, I think the number of deaths of healthcare workers have been relatively small, but it's not insignificant. And how are you coping with that? And you mentioned that you were really showering and all that before you came home. Is that still an ongoing issue for you and your colleagues?
I think as we learned a little bit more about how to protect ourselves, there were several things I think that made us feel better. First of all, the hospital environment became a lot safer with universal masking. I think that was a huge psychological shift in people's mind once that happened. But even then, I remember like it was ruled out in the hospital, but then not in the beginning applied to just outside the hospital. So I remember people even like this putting their masks down, but then you take the elevator to go up the, the UCSF parking lot, and like everybody was like there.
Right.
But it was rolled out eventually where we felt safe. So I feel like now people are, trying to do as best as they could. Some people are still quarantining a little bit if they're on a heavy COVID rotation service and then going home. But I would say most people are sort of at peace with how they can protect themselves and their families at home compared to those early days.
So this is a tangent again, but I remember this pandemic really hit me in the face. One day I was getting on the shuttle at Parnassus, that's the main UCSF campus, or at least the original UCSF campus. And right outside the emergency entrance, there was this blue Quonset tent that was being constructed. And I went, my God, this is maybe this is real. And then we all kind of had that accelerated phase where suddenly it went to work from home, shelter in place, and obviously we're still to some degree recovering from all of that. So this is at the time when we're meant to kind of open the questions up, and I think that the issues that I've already seen in some of the questions are, one of the questions is this intersection between HIV and COVID. I think we can put that to bed pretty quickly, Peter, but you might want to touch on that. And then another participant said that just heard today that Moderna has added HIV infection as an exclusion for their vaccine trials, which I don't personally think is necessary, but you want to comment on the HIV COVID part?
Yeah, so we were in the beginning of COVID fearing that HIV patients would be disproportionately affected and have worse outcomes. But so far, it seems that, and I can say the same for transplant patients as well, it's less about the immune status of the patient. In fact, some people think it actually is modulating it in a positive way because of the inflammatory response that's cause of a lot of the deaths.
Yeah.
But it has more to do with the surge in the particular city rather than, our ability to take care of immunocompromised patients and have them go through with a good outcome. In terms of the Moderna vaccine excluding HIV, I think that's a travesty. I think we need to know if our HIV patients respond to vaccines because everybody's going to get the vaccine.
Yeah, obviously. A person on the call who does tracking in Michigan says, "Why do we?" And this came up again, I think, just yesterday in the press. Why do we use fever as an indicator? It seems like a pretty insensitive way of finding.
And that's our thinking has evolved over the months as well, as we realize exactly that people without symptoms can transmit. In fact, they are probably the heaviest transmitters in some cases. So the presence of fever is more theatrics. It's a metaphor for us taking COVID seriously by having people remind themselves, but from a biological and medical perspective, it makes no sense. That's why symptom screening in colleges isn't as good as testing, and that's why people move to testing. And it's, again, very similar to the evolution in thinking with HIV. It's like saying, let's wait until you have like generalized lymphadenopathy before we think you might have HIV.
I remember posters in the gay community during those days of saying no test is best. So people feeling, why should I be tested? Obviously because we didn't have treatments at that time. But
so a testing strategy is really better, much better than a symptom checker. And when you look at the progressive countries like Hong Kong, they actually test everyone when they go through the borders using saliva. We don't do that, and that's been, I think, one of our limitations in the US.
So no one has asked this directly, but you mentioned testing, and give us a really, really quick thumbnail on which tests and when you use them, and what's the status of more widespread testing.
Yeah, so the two big boxes of tests are, you check for the virus itself, the RNA, or you check for the antibody response. We all know that the antibody response, we don't know what it means if you have it. There are like more than 100 different antibody tests, etc. I'll focus on the checking for the virus itself. There's like super good ones, and then there's less sensitive ones that are easier to do, that take fewer time, cost $5, etc. The super expensive ones, we use them in the hospital. They're like very sensitive, and we know about them. The less sensitive ones, they're cheaper. The antigen tests I'm talking about, Abbott is one of the tests that people have read about that may cost $5.
5-minute results.
Yeah, and 15-minute results.
Yep,
in the absence, and the technology is actually to have this available at home, like a pregnancy test, actually using laminar flow. But it's just whether or not the FDA will approve such a test, because that it's not as sensitive. But from modeling from Mina and others at Harvard, that if you do it enough times and it's easy to get like a cheek swab, the idea is that the cumulative sensitivity would make up for the absolute lack of sensitivity. Yeah. And be a public health intervention itself. So that's kind of how the tests go. And in terms of the platforms, you can have the most pain, which is like sticking it up all the way and like getting a brain biopsy, less pain, which is like the middle terminates, and the least pain, which is my favorite, which is spitting in a cup, which the MLB has done, but that hasn't picked up as much in the US. So I'm really for the least pain and maybe not as sensitive, doing it frequently.
I'm for that too.
Yeah.
So another pioneer, Bill Owen, asked a great question. A patient has had a prior bout with adenovirus 5 years ago. Does that affect your thoughts about whether a vaccine is dangerous? Is it safe? Is it effective?
That's a great question, and that's actually not a very commonly talked about topic yet. I think it's a very important topic. The idea is this idea of what we call antigenic sin. So basically the idea is like you've been exposed to something that looks like COVID, so your body's kind of like revved up already. So when the thing that looks like the other thing that looks like COVID comes along, which is COVID-19, you have this dysregulated antibody response, ADE as called, and that's why dengue is bad, because the other strain comes and like you already revved up and your body goes crazy. It can also work against vaccines because you have the new antigen coming in and somehow your immune system isn't going to bother to make new antibodies, just bringing up the old guard, the old soldiers, and already kind of thinks it looks like that. So I think it's a very prescient question and one that I think needs to be worked out.
Let me go to a question that may be one of the most important ones today. I'll read it verbatim because it's nicely stated. What can the medical community do to address the disinformation coming in from the federal government? How can we speak in a single voice?
That's one of the
tell us the answer.
I want to turn back to you, Paul, but I would say that I'll talk about my experience and the way I've seen activism work is actually through us, through the providers, not through some card-carrying activists. I wasn't like I'm sure that was the same for you, Paul. I didn't come into medicine saying, I'm going to be an activist and change the world. I mean, not that I'm doing that now, but I was part of a movement of people who were really mad and upset that the things that we're hearing from the top was so against the science. So that's the first thing I would say, like using science that helps to move people. Surveys in the US still show that the American people, the vast majority, still trust scientists and clinicians when they speak to them. So even though it seems that nobody's trusting, we do have that voice. So using science, speaking up. socializing, not doing it alone in a group. So like, I'll give you one example around the George Floyd protests. On a Sunday, I was like minding my own business, and some colleagues from University of Washington said, "Hey, Peter, we're working on this petition. We know that people are protesting against George Floyd, and I know a lot of people are going to say it's going to be bad for COVID in terms of transmission." So the way we moved that petition was to say it was a response to structural racism. Just like you wear masks as a response to COVID, you protest as a response to structural racism, which was a healthcare. So that narrative, working as a group, really helped. And I wasn't like running and laying in front of a door and going on a hunger strike. This was all done on social media in a very quiet, consensus building group way. And then addressing policy like you all done in HIV is probably the ultimate benefit. And that's, I think, where we're working on with decarceration or banning tear gas, those kinds of things.
And I just add that just as we saw with the HIV epidemic, those of us that were working with the media made ourselves available and really thought about how we're communicating. I'm really encouraged by seeing that. And I think at first, most of my friends who were, in your position were a little bit hesitant about directly criticizing the federal messaging. But, I think, boy, Ashish Jha and Carlos Del Rio have been very willing to do that. And I think, I think that's another thing that we should really encourage. We should thank our spokespersons for that. So great. So quick.
Can I just say one thing about Carlos?
Yeah.
I thought to myself, if Carlos can do that, surely I can do that.
So really quick comment. This is from somebody at the Harvard T.H. Chan School of Public Health about fomite transmission. Has that been laid to rest?
Yeah.
Can we bring our mail in and not let it sit out for 2 days?
Yeah, definitely don't clean your iPhone every 10 seconds. Focus on the 3 W's. Wearing your mask, washing your hands, and watching your distance. I think the messaging is simpler, and you can just focus on the most important things.
Yeah, I think the simpler the messaging, the better in terms of its effect. One of the participants wants to know something about post-COVID complications and some of these cases of really long-term residual damage.
Yeah. So they're called the long haulers. It's probably not, we don't really know the extent of it yet, but certainly there have been really bona fide cases of people, I think famously written about by Ed Young in The Atlantic as really bringing it to people's awareness. And then later on in subsequent sort of like the lay press, and then it's being studied now at UCSF and other places in these longitudinal studies of people with chronic conditions, but they're actually pretty mind-blowing and surprising and really taking a toll on people's life, like the smell of burned cigarettes or forest fires, the brain fog.
Oh, we have the smell of forest fires.
I know, the real smell. Yeah, I know it. People were describing that even before, and then now everybody's smelling it. So
yeah. So Gwen Scott, I'm sorry to keep picking up my favorite heroes around the country, but Gwen, who's been leader in pediatric HIV, asked about the flu season. What are you doing? Apart from, I hope, getting your flu vaccine?
Yeah. So I think there's both the good and the bad with the flu. The good is that I think people are going to be wearing masks because of COVID. So it's spread in the same way as everyone knows in the call. So the hope is that the flu season would not be as bad normally. But the bad is that, there are several things about the bad. The first is that people do get hospitalized with flu. And this time last year, we didn't have COVID as we knew it in the hospital system. We still have like 20 to 30 patients in this one hospital I'm at now. So even though it's lower in California, they're still simmering. You put you put influenza hospitalizations on top of that, and you become very tenuous as a hospital system. The second aspect is biological, and it will be interesting to see how they work bidirectionally in terms of risk. In other words, we know that influenza increases your risk for bacterial infections like MRSA and staph. Would COVID or flu increase the risk of the other coming in? And what about dual infection? So those are all questions that we'll have. And even simple questions like, should I get the flu vaccine now, or should I wait if they figure out they made a mistake with the flu vaccine, they make a better one later on? So, they're all questions that we have with flu. And the summary point is, I think it would not be as good as if we just had COVID alone because of all those reasons.
Yeah. So Jeff Taylor, who's a very involved HIV activist, says he believes that Moderna has changed and is now allowing HIV. I'm not sure he has a URL that I'm not going to click because I don't want to screw up the webinar. And then someone else comments about Pfizer allowing HIV. Is there kind of, do you know?
I don't know about Pfizer and Moderna, but I do know that AstraZeneca, I believe, has a trial in South Africa with HIV-infected patients getting the vaccine. But I don't know about those other two companies. I think it would be important to include them for sure in trials. Because we just need to know if the juice is worth the squeeze, and different vaccines will probably have different efficacies in our most vulnerable patients, and we just need to know that information.
Here's a really great question about the intersection between the adenovirus vaccines and stem cell fetal research, that saying that there's some opposition to vaccines within the Catholic Church for vaccines that are made using some of this technology. What do you think about that? Is that something that we should be paying attention to?
I mean, so far the sort of buzz has been low. Luckily, hopefully people will just focus on the idea that it's a public health pandemic and not think about those nuances, because again, we all need to reach up to that herd immunity if we are to keep ourselves, the vulnerable people who can't get vaccinated, safe. And the other issue that came up too is the issue of monkeys, because you do need monkeys, and it's the same issue with HIV research too. Monkeys are essential for the first stage of vaccine trials, and because of the decimation of monkey infrastructure for research in the US after HIV, it's been very difficult for researchers to do vaccine studies in the US because they can't get the monkeys. They all come from China, and we have tension with China, so we can't get those monkeys over. So I think that's another group that's been people worried about.
Great, and there seems to be a growing consensus among the Q&A side of this that Moderna does allow HIV and Pfizer as well. So thanks for the feedback on that. One of the questions was about some of the oral symptoms, eye problems, blurry eyes, red, yellow eyes. Are there some ocular stuff that's not being captured in some of these?
I think there are ocular abnormalities. It's just not a feature of them standing alone. In other words, you wouldn't get conjunctivitis with nothing else. They usually, right. At least the studies I've seen, they usually happen in concert with some of the traditional things we think about. I remember Carlos Del Rio early on told me there are two things he does every time he wakes up in the morning. He checks to see if he has a temperature, and he smells his coffee. If you can smell his coffee and he doesn't have a fever, he's good to go for the day.
I basically do the same thing. I got a pulse ox too, just in case, but I so far haven't been monitoring my pulse ox. We are at the end of the hour. We have really great questions still that I didn't get a chance to address. Peter, you've been spectacular. I think people can understand why you're such a popular teacher here at UCSF. And
I'll show them everybody my COVID plush toy too. You can order it as well. I ordered it in April and it was back ordered until July. I guess everyone was. And on various other webinars, I think people have been showing their Fauci t-shirts and bobblehead dolls as well. So great. I think I have another slide to show.
We still have, we got up to about 160 people on the program today, and thanks to everyone for joining us. We're going to keep doing these. So this is a way to see what's coming up from IAS-USA activities, including these dialogues, we call them. By the way, this doesn't earn CME credit. I'm sorry for that, but it makes it a whole lot easier to organize these. And I hope they're still useful even without the CME. So thanks for staff IAS-USA helping out, and we'll let you get back to your day. Thank you.